to this presentation on acute bacterial meningitis for MDM 158, the acute and emergency paediatrics module of the Master's Programme in Clinical Paediatrics and Child Health at Brighton and Sussex Medical School. My name is Carmel, and this presentation is about 60 minutes long. Two of the main sources of information, the NICE guideline on bacterial meningitis and meningococcal septicemia in children, first published in June 2010, and also the evidence update from January 2012, as well as the most recent update in 2015, are included in some of the... I'm going to cover some of the pathophysiology and epidemiology to set the context and also focus on the under 3-month-old group because of the greater risks in this age group. We'll review the evidence for symptoms and signs, the diagnostic tests, treatments including antibiotic, fluid management, and the controversial role of steroids, look at the outcomes and also aspects of longer-term management. Start with a bit of pathophysiology, just that we're all clear. Bacterial meningitis is an infection of the meninges, the surface of the brain, by bacteria, and usually they will have travelled there from the mucosal surfaces via the bloodstream. And the emphasis on via the bloodstream is an important point because it helps us understand, for example, the link between meningococcal meningitis and septicemia, and also why pneumococcus, which is known to have particular stickability to low flow blood vessel endothelium, also is associated with more vascular complications than other forms of bacterial meningitis. And on the picture here on the right, you can see how the bacteria go from the upper respiratory tract or the nasopharyngeal surface into the blood and then through into the meninges and cause inflammation in the subarachnoid space, and therefore can cause swelling and pressure to compress the brain tissue, swelling which also puts pressures on arteries and reduces blood flow. And in number 4 at the top, you can see swelling increases intracranial pressure and causes additional problems. This swelling also can compress nerves, and in particular can compromise the blood supply in the cochlea, and hence the side effect, or the complication of deafness. Now, the commonest bacteria in the over 3-month-old tend to be those that are found in the respiratory tract. For example, in the case of Neisseria meningitidis, we know that 20% of the population have it on nasal swabs, but doesn't commonly cause localized infections. We also know that Streptococcus pneumoniae is a common cause for upper respiratory tract infections, including pharyngitis and otitis media. And as we shall see later, when we look at symptoms and signs, that the presence of otitis media or pharyngitis doesn't exclude the possibility of meningitis. And to be aware that there's a common kind of bias, something which we'll explore further in another part of the course, and that is the bias to stop looking when one thing has been found. As you can imagine, in the case of Streptococcus pneumoniae, otitis media and meningitis, this could lead to a diagnostic error. And really the only way around that is to mentally actively exclude meningitis and to be able to articulate clearly, for example, in the notes, why it has been excluded. The other common organism is Haemophilus influenza type B. And then if we look at the neonatal group, there's a different group of organisms. Group B, Streptococcus and E. coli predominate, with strep pneumoniae being a little less common, and in the under 1 month old group, particularly Listeria. And these are usually organisms that are going to be acquired perinatally from the maternal genital or gastrointestinal tract. Let's have a look at the epidemiology, and here's a graph showing the incidence of invasive meningococcal disease notified to Public Health England by age group between 2007-8 epidemiological year and 2016-17 epidemiological year, and the different coloured lines represent different ages. The reason I've drawn a circle around 2007-8 is because that was the year up until which the evidence that went into making the 2010 NICE guideline was reviewed, and at that time the incidence, as you can see, compared to now, was significantly higher. And since then, the case rate, the incidence has fallen by at least 2/3. And within this, we can see that the dramatic success has really been in the under 1 year group, where the incidence has fallen from 45 per 100,000 population to almost 15. And really, this is a testament to the success of the UK meningococcal vaccination programme. In the 2016-17 year, we can see that if we add up the total incidence in the under 1 and the 1 to 4 year old group, we get roughly 20 to 25 per 100,000. And one reason for finding this useful to do is that there's population data for Sussex of this age group available from 2011, and this shows that East Sussex population is 27,887, Brighton and Hove is 17,100, and West Sussex is 92,814. And so the overall incidence is going to be roughly around 7 cases a year in East Sussex, maybe 5 in Brighton and Hove, and because of its significantly larger population, around 23 cases a year in West Sussex. Let's now look at pneumococcus, and here's different coloured graphs representing different years. So similarly with invasive pneumococcal disease, and that's what these graphs are showing on the y-axis, the cumulative number of reports. So this will include septicemia, pneumonia and meningitis. We can see similar patterns of reduction for serotype organisms covered by the Prevnar vaccine. And this vaccine is currently given in the under 4 month olds, and as you can see from the graph, the top green line shows at the end of week 26 in that year, the total number of reports accumulative was almost 250, and that, in fact, almost 275, and that this has dropped dramatically when we look at the red dotted line at the bottom, which is 2015-16, all the way down to almost 20 or 25 cases a year. And that's a further reduction from 2010, which you can see as the rust coloured line, when Prevnar 13 was introduced 7 years after the original Prevnar in 2006. It is very much the same when we look at Haemophilus. And this is perhaps the biggest success story with Hib vaccine. And you can see in this graph this dramatic fall, really, and sustained, really, all the way from about 2009 onwards. But that huge number of peaks before 1993, before the vaccine was introduced, and then a slight peak in 2002-03 when a catch-up vaccine program was introduced. So, if you look at 2014 onwards, the numbers are really so low. And that would explain why I haven't seen a case of Hib meningitis for almost 10 years now. And so, this significant reduction in the incidence of the 3 commonest bacterial causes of childhood meningitis begins to raise some questions about the nature of meningitis in the UK in 2018, and really questions the evidence used to create the NICE guideline and whether this is as relevant as it needs to be. The incidence now being so much lower, maybe the presumptions about, for example, diagnostic tests and therefore the sensitivity and specificity in those populations back in 2007 and 8 compared to 2018 really might have quite big implications about what kind of tests we do. And so, just an example, a test with a sensitivity of 90% on the face value, sounds impressively high and will appear to be working at picking up lots of cases. And that will be true when the background incidence is relatively high. But when the incidence falls, let's say, for example, by 10-fold, as has in the case of some of these invasive diseases, then actually even a 90% sensitivity no longer is good enough. And this is actually an even bigger issue when we look at specificity of tests, because the false positive rate climbs significantly under those circumstances, and we end up over-treating really quite large numbers of children. And of course that's perfectly acceptable if the unnecessary treatment comes only with a limited burden. But those of us who manage these children know that that's not the case. So for me, I would now begin to question how valid is the evidence back from 2007-10 compared to what we're faced now. Well, we'll come to that later. But firstly, in terms of epidemiology and numbers, there's a particular group that within the under 1-year-olds that deserves a further mention. And this is the under 3-month-old group. And this is because the incidence is so much higher and the causal bacterial organisms are a bit different compared to older children. And what is surprising is that within the success of reducing meningitis incidence, that we have had no effect in this age group over the last 3 decades. And here is the reference for this important observation. And here's a table from a similar paper showing the incidence analysis between 2004 and 11. And you can see in the second row, the 3 to 11-month-olds, the mean incidence is just under 19 per 100,000. And that there's an annual trend estimating -9, so a decrease by 9% annually. And that the confidence interval for this estimate of 9% is between 7 and 11% reduction annually. And we can see that the incidence is also far lower in the 1 to 4 down to 2.5 per 100,000 and so on as you go down. But then when you go back up to the under 3-month-olds, you can see that the incidence is 7 times that in older children and adults. And furthermore, the annual trend analysis shows a 95% certainty that the incidence is actually rising by between 5 and 9.8% each year between 2004 and 2011. If we look at the causal bacteria, and this graph shows the incidence of the 5 commonest causes of meningitis in under 3-month-olds. The commonest bacteria being group B strep or strep gallicti, and this looks like it has risen a little since 2004, and that's the green line at the top. The second most common is the pink circles, which is E. coli, and it's interesting to see that the purple circles, which is Neisseria meningitidis, was falling from 2004 onwards and has stayed stable and low since 2009. So it looks like as if 2/3 of the cases are caused by bacteria for which there isn't currently a prevention program, and this partly explains some of the reason for the higher incidence in this age group. But we'll see later in this presentation that there's also further work that could be done around how well and quickly we recognise the possibility of bacterial meningitis in this age group. What I think kind of makes sense now is really to move on to what NICE has to say about the evidence on symptoms and signs that we use to recognise meningitis, and as part of that review we'll also focus separately on the under 3-month-old age group. So the NICE guideline was published in 2010 with an evidence update review in 2012, which led to no major changes in the guidance on treatment. And in 2015 they decided there wasn't any new evidence that materially changed the guideline, except to say that there's no role for doing a bacterial throat swab in diagnosing meningitis. So there were 5 main areas that the NICE guideline focused on, and we're going to go through 4 of them. So that's symptoms, signs and initial assessment, diagnosis in secondary care as well as management, and long-term management. So firstly, with symptoms and signs in the over 3-month-old group, there were 8 studies over a 15-year period looking at symptoms and signs, and they categorised them as either common, less common, or more specific for meningitis. Let's review the common ones. So here they are. There's a table with the left-hand column representing these common signs and symptoms, and the third column labelled all children shows the percentages of patients, and the hyphen is the number of studies out of the 8 that looked at this, and the under 2-year-old column shows the presence or the incidence of these signs and symptoms in the under 2-year age group. And as you can see, that really the common symptoms are really non-specific, which means they could represent a number of alternative diagnoses. And so you can envisage that really with early presentation, it could be difficult to distinguish early meningitis or sepsis from a less serious viral illness. It's worth perusing this table and for a little while, and I'll leave you to draw any other conclusions from the data presented, and I suggest that you might wish to pause the video just to have a look a bit more closely. Now, if we move to the less common, there are 3 categories there, and only really one, which is ENT and respiratory symptoms and signs, were looked at, and that included 5 studies. And where they were looked at, the respiratory findings were defined as chest x-ray findings with 12%, and ENT findings were mainly based on the presence of catarrh, which was found in 40%. So to me, this really emphasizes that you can have coexisting catarrh or evidence of an upper respiratory tract infection, and so in such patients one has to actively mentally rule out meningitis before you can attribute any febrile illness to an upper respiratory tract infection. Let's move on to the more specific signs for meningitis, and there you can see there it's quite a large list, and some of them have been studied in all children and some in only under 2-year-olds. And what strikes me immediately when we look at this is really how low the prevalence of these symptoms and signs improve in cases of meningitis. So, for example, even that 83% had a stiff neck, this really means that 1 in 5 didn't. And the presence of stiff neck is only up to 56% in the under 2-year-olds. So a fairly common sign that we rely on to maybe screen for meningitis doesn't actually have that higher incidence. And also, likewise, if you look at bulging fontanelle, under half of the patients had that. So really the problem is that symptoms and signs are difficult to rely on when differentiating meningitis from other acute illnesses, and the younger the child, the less specific they're likely to be. So we can then expect to be screening children for this, and this is going to end up including having to do a lumbar puncture. And what I don't know is really how many negative lumbar punctures represent a decent screening rate. So, how many lumbar punctures do we need to be doing which are negative in order not to miss the few that might have bacterial meningitis? And what NICE has said is that signs and symptoms don't help to differentiate certainly bacterial from viral meningitis. Now let's look a bit more at the under 3-month group, where a similar analysis of signs and symptoms had been by Okike et al. And this paper was published in January 2018 and analysed 263 notes of babies with meningitis. On the left-hand column we can see that the estimated prevalence of fever is astoundingly only just over half, seizure is under a third, and bulging fontanelle is a fifth, with coma and neck stiffness being really uncommon. The right-hand column shows the odds ratios of, in the top, mortality and what factors predicted mortality. So prematurity meant that you had an odds ratio of just under 6 for mortality, so you're 6 times more likely to die than if you're not premature. Low birth weight, 8.5 times, and if you're in a coma, then 31 times more likely than if you're not. And pneumococcal, which we know is historically associated with a severe form of meningitis, increased the risk by 4.5-fold. And if we look at complications, then temperature instability, particularly seizures, and if you had a very high protein count. Also, pneumococcal disease was associated independently, each of them, with getting CNS complication. And in this cohort, 9% of the infants died, and 23% had CNS complication, which included either developmental delay, motor delay, new onset epilepsy, hydrocephalus, or hearing delay. So here, one of the take-home messages really is that we can't even rely on fever to screen who may or who may not have meningitis, and you have to be much more aware of the other types of symptoms and signs. And so this group additionally did a further review where parental questionnaires and asking families to write down what symptoms they had were analysed. So this is under the banner of an assessment of healthcare delivery, and 97 cases where they had available both parental questionnaire results and notes were reviewed. 66 of these babies were admitted from home, and 31 were already in hospital when the diagnosis of meningitis was made. And one of the key features was that the symptoms at onset, as reported by parents, didn't appear really to progress very much in the first 24 to 48 hours. And these symptoms included poor feeding, lethargy, fever, abnormal cry, irritability, breathing difficulty or abnormal movement, and bulging fontanelle. So to me, this represents the possibility that really, if any of these features are there, then it gives us an opportunity to recognise early and consider a low threshold for screening such children. And here's the data represented in graphic form. So the top two graphs show the time at which parents first noted each of the specific features, and each coloured line represents one of those clinical features. So top blue line is poor feeding, there's an orange line for breathing difficulties, and you may not be able to see individually exactly what percentage each one is, but you can see clearly that in the top graph that most of those features were noted at onset, and that the percentage of babies who had those symptoms didn't really change in the first 24 hours. The bottom bar graph shows in blue the percentage of infants who had those clinical features at onset, and in red those features that were present at admission. And there's a slight increase in poor feeding, slight increase in fever, irritability and breathing difficulties, as well as abnormal movement and bulging fontanelle, but really not very much. So most of these features were there at onset. And really, therefore, I think this means this gives us an opportunity to understand that if any of these features are present and parents are reporting them, then bacterial meningitis has to be seriously considered as a differential diagnosis and has to be actively ruled out. So this means, if you're in primary care, referring to hospital. If it's in hospital and people aren't sure, then to have a senior review, and that might then decide a strategy of either continued observation or going straight to a septic screen and a lumbar puncture. From this study, this next table shows the mean time to first dose of antibiotic from onset, depending on whether the babies first were taken to hospital, and you can see in the right hand column there were 20, or if they went to hospital from the GP or some form of primary care, and that is 31 infants. So actually more parents go to their GP with these problems than go to hospital. So, and 15 infants went to hospital from the GP and were sent home and went back to hospital a second time. And you can see that there's a significant delay in time of onset of symptoms to the first dose of antibiotics, particularly in that group who were sent home and then reattended. Now the numbers really aren't high enough to show any rate of poor outcome being statistically different, whether you presented to hospital after 24 hours, and that was 8 out of 15, or whether you presented within 24 hours and had poor outcome, which was 18 out of 47. And the interval between triage to first antibiotic dose wasn't associated with poor outcome either. But of course, all it takes is, one extra patient in the 15 group to have had a worse outcome, and one patient who presented within 24 hours in the 47, n equals 47 group to have better outcome, and the figures are all completely changed. So, what therefore do we need to know about how to recognise? Well, the Meningitis Research Foundation has produced this poster, Meningitis Baby Watch, and it lists in a parent and healthcare professional friendly way all of the symptoms and signs to look for to be aware of in babies presenting with potentially serious illness. And this is information taken from both NICE and also the 3 papers by Acute et al. I'm just going to pause here so that you can digest all these symptoms a bit more fully. And you may wish to pause the video. In addition to this, the Meningitis Research Foundation has also published an e-tool about neonatal meningitis to increase and improve awareness among healthcare professionals. For hospital management, there's also an algorithm, and an example of that is on the bottom right. And really very helpfully also, on the bottom left, you can see the lumbar puncture parent information sheet, which really could help most professionals when discussing and negotiating the use of lumbar puncture in a parent's child. Because quite often that's a bit of a tricky hurdle that we need to get over, and any help we can get is going to be useful. So, talking about lumbar punctures, this brings us to the topic of diagnostic tests. And so firstly, we want to know, I guess, after symptoms and signs, what's the evidence for using blood tests, and are there any ones that are helpful? And what NICE has concluded is that for bacterial meningitis, well, if you want to exclude that compared to other febrile illnesses, tests don't help. And some of them might help in differentiating bacterial from viral meningitis. One of the ones we commonly use is C-reactive protein, or CRP. And actually, when I first saw this, I was a bit taken aback that a CRP of more than 20 only will pick up 83% of cases, i.e. it'll miss 1 in 5. Now, the 2012 NICE guideline update suggests using a cutoff of CRP of 100, which is interesting. And if we're going to also, together with that, use white cell count, then the 2012 update suggests a white cell count of greater than 16 as the cutoff value, but greater than 15 only has 62% sensitivity. And when we look at neutrophil numbers, the sensitivity isn't really that much greater. So, and remember, a lot of these were done in the 2007-2010 era, when the incidence was dropping, but not as low as it is now. So, what about the promise from the use of procalcitonin? What NICE have said that although in some studies it suggests a 90% sensitivity, the evidence update in 2012 said that procalcitonin levels didn't appear to contribute any additional specificity to the currently used tests. So, if these aren't so useful, what about something that we regard as more gold standard? The analysis of cerebrospinal fluid, CSF, which is obtained by lumbar puncture. Now, if we use a cutoff of more than 500 white cells per microliter, the sensitivity isn't particularly high, and the negative predictive value is not particularly high. It means that if you have a white cell count less than 500, then you might miss between 1 in 5 and 1 in 10 cases where meningitis still is present despite the CSF white cell count being under 500. And there's no clinically reliable threshold that helps distinguish bacterial from viral or aseptic and also non-bacterial meningitis in children or in neonates. So just bear in mind that the cutoff values that we currently use have not been necessarily rigorously tested in a prospective randomized fashion. We often worry about the risk of cerebral herniation and whether this could be made worse or caused by lumbar puncture. Well, the problem is that there's already an increased risk of cerebral herniation in bacterial meningitis, especially if there's significantly impaired consciousness or other signs of raised intracranial pressure. But again, there's no trial data to help conclude whether or not lumbar puncture causes cerebral herniation in bacterial meningitis. And I think the adage from most pediatric neurologists is that if you have a fontanelle, then it's safe to do a lumbar puncture from a point of view of cerebral herniation. Now, of course, some people have thought about using a CT scan, but NICE suggests that CT really is too unreliable to identify risk of herniation from raised intracranial pressure. Now, the 2012 update reviewed a couple of what are called clinical decision rules, and one of them was the bacterial meningitis score shown here on the left. And this was derived from assessment of children in pediatric emergency room or intensive care setting based on 198 children under the age of 18 from 6 centres in 5 European tertiary care hospitals, and the bacterial meningitis score, which obviously requires, as you can see there, a lumbar puncture to have been done and analysed, and the analysis in terms of gram stain, protein, blood neutrophil count, spinal fluid neutrophil count, and whether there have been seizures can be put together to form the bacterial meningitis score. The sensitivity is 100%, but the specificity is only 52%. So if you put all these together, and they, however, if you have 1 point or less, then, well, in fact, if you have 0 points, then it suggests an almost 100% negative predictive value, but only in children over the age of 2 months. So, despite highlighting the issues about cutoff values in blood tests and CSF, we've still managed to diagnose children, and we've still been treating them for meningitis with clearly degrees of success. So I think we'll leave the shortfalls of our tests, and let's proceed with reviewing the evidence for treatment. And NICE covers the choice of antibiotic. Please note that there's no controlled trial data to inform the duration of antibiotic. NICE also has reviewed the issue of fluid, the controversy around steroids, and also looking at longer term care and follow-up. So if we start with steroids, there's data from just under 1,400 children which showed no difference in mortality rates in randomized controlled trials of different antibiotic regimes. Now, I'm certainly going to interpret this with a caveat, because the mortality rates in the trials were lower than those compared to the reported mortality rates in case series. So perhaps they were using children with less severe disease when they were looking at mortality. Hence, they weren't able to show any difference. But also that means that we need to perhaps be aware of this and not rely blindly on the antibiotic regimes that we have. One study which assessed pharmacodynamics suggested that ceftriaxone sterilized CSF more rapidly in a trial of 100 patients. And what the NICE guideline suggests is, because they also do a cost effectiveness analysis, that in the under 50 kilogram patient, ceftriaxone is more cost effective, and that's mainly because of reduced staff costs that they've estimated, and that if you're over 50 kilograms, benzoyl penicillin becomes more cost effective because of the cheapness of its dose. Now, fortunately, there is currently really quite a low prevalence of pneumococcal resistance to cefataxime and ceftriaxone. Around 1 to 1.7% of strains have been reported to have either intermediate or high resistance to cefataxime between 2004 and 7, and that source is from the Health Protection Agency in London. There are no studies in under 3-month-olds and no studies on the duration. So understandably, most hospital guidelines have cephalosporin as their first choice. on to intravenous fluid, and most patients will end up receiving this, which is understandable because poor feeding, vomiting, lethargy are really quite, or relatively common. And when a meta-analysis of 2 trials of 407 children between the ages of 1 month and 12 years was analysed, they found no significant difference in mortality between the maintenance and restricted fluid groups. So mortality in the maintenance group was 15%, and in the restricted fluid group was 18%. The larger of these randomised controlled trials was actually done in Papua New Guinea, and this was 357 children, and what they found was that significantly fewer children who were given maintenance fluid had spasticity or seizures in the short term compared with children given restricted fluids, and that's spasticity at 14 days with a relative risk of 0.53 and seizures at 72 hours, relative risk of 0.62, and both the confidence intervals were below 1. What NICE says in addition is that in the context of suspected raised intracranial pressure or hyponatremia, particularly if there's suspected increased ADH or antidiuretic hormone, then to seek guidance from expert input from a paediatric intensivist. So although there's no clear evidence to suggest that maintenance is better, there is a trend towards that, particularly in low-income countries where children are likely to be sicker and where malnourishment is an issue. It may well be that we get away with being able to restrict children who don't have hyponatremia because they're not malnourished and because they don't present as late and don't have as high a mortality. Now, steroids were used for treating cerebral edema really since the 1960s. And in the 1980s, animal models showed reduced subarachnoid space inflammation in meningitis with the use of steroids. So trials have been done ever since, particularly when streptococcal meningitis prevalence had been very high, especially in adult patients where mortality and neurological sequelae were especially high. And there's mixed kind of data. NICE have reviewed 1,000 children in 11 randomized controlled trials and showed no effect on mortality. That it does, however, appear to reduce severe hearing loss in Hib meningitis, but the evidence is less clear in strep pneumoniae, conversely to what is seen in adult patients. It certainly appears to reduce long-term neurological sequelae, and there's a question of whether the timing of the dose in terms of before or after antibiotic is an issue. Theoretically, the bacteriolysis caused by the antibiotics can cause further neurotoxicity, and it is this that steroids are thought to attenuate. So far, the studies appear to have shown no harm, but then the studies weren't perhaps designed to look for long-term harm from steroid. Here is a forest plot looking at meta-analysis of 4 studies suggesting that the timing of steroids on long-term neurological sequelae is a significant factor, and that if antibiotics are given either before or with the first dose of antibiotic, you can see that the result favours the use of steroids, whereas if it's given afterwards, there appears to be no benefit. When we look at the forest plot data for timing of steroids on severe hearing loss from Streptococcus pneumoniae, we can see no real effect, but a trend towards it being beneficial either with or before the first dose of antibiotic. But as you can see from the total numbers of patients, they're actually very low. So what does NICE say? It suggests that steroids could be used when there's strong evidence of bacterial meningitis, but only in the over 3-month age group. Now, ideally, the steroid should be given in the population that matches those that were treated in these trials. So that's children whose CSF white cell count is more than 1,000, who are gram stain positive and have CSF protein more than a gram per litre. And of course, most paediatricians are pretty unlikely to wait for these results before starting antibiotics in this day and age. So really, there's a bit of an issue there in that antibiotics are likely to have been given before the results are available, and that giving antibiotic after the giving steroid after the antibiotic appears not to be as beneficial as giving it before or with the antibiotic. And of course, with the significant fall in the incidence of bacterial meningitis in developed countries with our vaccination programs, there's perhaps also the risk that we're unclear really about the harm in aseptic meningitis or even in TB meningitis, which obviously isn't such a big issue for us here in Sussex perhaps, but might be in inner city populations in the UK. I want to just mention about the concept of secondary brain injury, and this is going to be covered in a little bit more detail in the presentation on traumatic brain injury. And NICE doesn't cover any of the treatment of complications, so I just want to mention them. Seizures requires anticipatory approach, and we would follow the APLS guideline, and this is covered in significantly more detail in the status epilepticus presentation. The management of raised intracranial pressure, there's a nice précis and summary in up-to-date 2018 about what symptoms and signs to consider in recognizing the possibility of raised intracranial pressure, the initial management, which includes, importantly, keeping the head upright in the midline and using either hypertonic saline or mannitol, and even considering prophylactic antiepileptic. And equally importantly, being vigilant about the possibility of hypoglycemia, as well as electrolyte imbalance, and in particular hyponatremia. And there's a suggestion that keeping sodium levels above 145 at millimoles per litre is associated with improved outcome in traumatic brain injury, and that may be also true, therefore, for brain injury from meningitis. In terms of outcomes, the NICE summary notes the high incidence of moderate or severe disability with Group B strep, with 29% of survivors showing moderate to severe disability, and that's 3 studies. With Streptococcus and E. coli, with almost a fifth of patients similarly, and much lower for Neisseria and Haemophilus. And of course, we've already seen that both Group B strep and E. coli are much more prevalent in the under 3-month-old group, and we've already seen that they tend to have a higher rate of morbidity. And that's probably because at that very young age, you've got the potential difficulty in early recognition and therefore delay in starting treatment, together with the greater impact of brain injury on this developing younger brain compared to older brains, leading to longer term neurological problems. So if we move on to looking at longer term care, NICE recommend that all children who have recovered from meningitis should have a hearing test within 4 weeks. And clearly there's a need for prompt follow-up, especially in the under 3-month-olds, and I think also in anyone who's had streptococcal pneumonia and meningitis. It's also vital that families know how to access further care, and that additional support and signposting is available from supporting organisations, and that they're aware of this. So I'm just going to now briefly summarise what we've done. We've gone through some pathophysiology and epidemiology, and we've focused particularly on the under 3-month-olds because of the fact we recognise that the rate or the incidence of bacterial meningitis in this age group has been increasing in the last decade. We've had a look at some of the evidence base for symptoms and signs in both age groups, and we're aware now that fever, for example, is not a useful screen in the under 3-month-old. Having had a look at the diagnostic values of these tests and perhaps understood therefore the importance of doing a lumbar puncture as something that's near a gold standard. And when it comes to treatment, the choice of antibiotic, there's still the unresolved controversy around steroids, and the outcomes determine something about our long-term management. So I'm going to finish. Thank you very much for listening. I hope you've enjoyed the experience, and I'm really looking forward to seeing you in the classroom. So it's bye from me for now.